Hello, everyone. Thank you for joining today's webinar, Scaling Patient Care, the Road to Controlled Hypertension. This webinar is sponsored by Validic. Validic is a digital health and personalized care company devoted to its mission of improving the quality of human life by making personal data actionable. With the world's largest health IoT platform and EHR-embedded remote care application, Validic helps healthcare organizations give every person tailored interventions and personalized care, improving healthcare efficiency and delivery, and empowering people to play an active role in their health and well-being. I'm Sean Edwards from the Healthcare Innovation Company and Validation Institute. I will be introducing our webinar today. Just a couple of quick announcements before we get going. Due to the number of attendees, participant lines are muted. However, if you'd like to submit a question for our speakers, please do so using the Ask a Question box that you see on your screen. We'll answer all questions that we have time to address during the program. Also, please note that this webinar is being recorded, and you'll receive an email with a link to the video so that you can view it again. Now I'd like to introduce our moderator for today. Eric Wickland is a senior editor at Innovation Technology Health Leaders. We are pleased to have him here. Eric, welcome. Without further ado, I'm going to turn it over to you.
Thank you, Sean. Yeah, I'm the moderator for today's discussion, so I'm going to be mainly in the background here and let these people talk. This is going to be a really good conversation of what I think could be a model for chronic care management around the country eventually. We have Kimberly, Isaiah, and Drew on this panel, and I'm going to go ahead and let them introduce themselves first before we get into this conversation. So let's start with Kimberly.
Good afternoon. My name is Kim Allen. As we close out May for Nurses Month, I want to introduce myself. I've been a nurse for 23 years in the greater Philadelphia area. I am currently the Chief Quality and Innovation Officer here at Delaware Valley Community Health.
Okay. Isaiah?
Hello, everyone out there. I don't know what time zone you're in, so good morning, good afternoon, good evening, doesn't matter. I'm Isaiah Nathaniel, Vice President and Chief Information Officer of Delaware Valley Community Health. More importantly, I'm an Eagles fan. So if you're in the Georgia area, we welcome you to be on our bandwagon. We go Dogs, and we're looking forward to this upcoming season as we get ready to defend and play a good game.
Okay. And last but certainly not least, Drew.
Awesome. Thanks, Eric. Isaiah, I actually grew up in Kansas City, so Eagles are. I was I was with you until the end, but I will. Yeah, I'm very glad to be a part of this group. I'm Drew Schiller. I'm the co-founder and CEO at Validic, and the Validic was introduced very well. Some really exciting things going on our side. Certainly the work that we're doing with Delaware Valley, which we're going to highlight in this particular conversation, with the amazing patient care that they've been able to bring forward. We also have recently added the additional capabilities of not just enabling technology or enabling personal health data with that technology that we bring, but also now adding full third-party logistics and shipping and tech support to really help give a full 360 perspective of all the different capabilities that patients need. So we're really excited about that. And in addition to my work with Validic, I'm also on the board of the Consumer Technology Association Health Division, which encompasses a wide variety of stakeholders across the healthcare spectrum as we're looking to advance healthcare and digital health specifically to better empower patients for better health through better access to care. So looking forward to the conversation.
Okay, great. Now, being a New Englander and a Patriots fan, we could have a great argument here about football. But let's go straight into this topic that everyone wants to hear about today. The program that you've launched. Kim, could you provide us some background on this program and some of its initial goals?
Sure. I wish I had some great sports analogy to tie this all together, but that is not my forte. But patient care is. So Delaware Valley Community Health started this journey in January of 2020. This was before we had that little thing called COVID-19 that was going to be happening in a few months. We had started with a small grant through our Health Control Network, or HCCN, which was the Health Federation of Philadelphia. We had started to look at our population health data related to hypertension control and had noticed that we had an equity issue at one of our sites. The Health Control Network, or the Health Federation of Philadelphia, was gracious enough to partner with us with some CDC money to be able to dig into this a little bit deeper. We quickly used evidence-based tools, platforms. We started to look at ways to reach these patients with an equity foundation. We were set up perfectly for the pandemic because we were able to capitalize on our telehealth visits with the technology that we had put in place in January of 2020, when the height of the stay-at-home orders came at the end of March into April. We continued to scale across our 9 sites in southeastern Pennsylvania to reach 50% of our hypertension patients within 2 years of the grant cycle. One piece I forgot to mention, so we started with a small grant from the Health Federation, and then in April of 2020, federal money was released to look at an innovative way to work with your hypertension patients with a digital tool. We did capitalize on the fact that we had a great foundation going on, and we were hoping that we'd be able to scale it quite quickly. In the 2.5 years, almost 3 at this point, we have been able to move our UDS metrics, or our uniform data set, from a low of 43.8% control rate in 2020 to a rebound of 65% in that 2-year time span. For those of you that do quality metric or clinical work, to move the needle 2 or 3 percentage points in a year is an achievement, let alone double-digit gains in a few years.
Okay. Let's continue that question with Isaiah. A little bit more background on the program. Could you explain how it works?
That's a good question, Eric. But what I want to do, even though you're a New Englander, I won't hold that against you in this webinar. Maybe later I'll hold it against you. But for now, I'm going to be professional. Now, seriously, let me talk about a little bit about Delaware Valley Community Health, because what Kim is suggesting from an equity lens, I want to put that into context. So Delaware Valley Community Health is a 52-year-old FQHC. And for those of you who don't know what an FQHC is, that stands for Federally Qualified Health Center. And our mission, there's 1,400 of us in the nation, and our mission is to serve the underserved. So for Delaware Valley Community Health, that's 9 locations in a 26-mile radius that stretch 2 counties, which in turn is 50,000 patient lives and then 158,000 visits in traditional primary care that we see. And so you can walk in our door with commercial insurance and we'll see you. You can walk in our door without any insurance at all, and we will still see you. And then being an FQHC, we are reimbursed by the federal government for that visit. So that's a little makeup of Delaware Valley Community Health. So when we talk about equity, when we talk about reducing access barriers, we're doing that at the ground level. So to do something at such a high technology and innovative level as Kim talked about, we're doing that for patients that are most vulnerable. So when we talk about a global pandemic, when we had to shut all of our doors to all of those 50,000 patient lives, and for us to be able to come together and say, hey, we still have a mission to serve these underserved in Philadelphia, and to do it from an equity lens, can't be so pleased that we have such double-digit gains as Kim talked about. But let me answer the question more directly, and then I'm going to turn it over to Drew, because I know Drew wants to jump right in after me. The balance of this had to be special. And you only can do things special when you have a great team. And from a technology perspective, my job as VP and CIO is not to say no, it's to say yes. I tell everyone at Delaware Valley, I'd rather a slow yes than a quick no. And so once Kim wanted to design a program using SMBP or remote patient monitoring under that umbrella, my answer wasn't no, it was, we can do this, and we can do it in the pandemic, as stressful as that was. And I'm so happy and so pleased that together, collectively, we've been able to do what we've been doing with this measure here.
Okay. All right, Drew.
Yeah, thank you so much. And I am really excited to participate in this conversation. And Isaiah, just to echo what you said, the mission to serve the underserved, I think is so critical. One of the things that we always highlight is that our mission is to improve the quality of human life by making personal data actionable. And that's all humans, right? Not just the well-insured. And so one of the things that I think is so important about this program, and that I'm excited to talk and learn more from you all about, is how you're able to take the technology capabilities and integrate that into your care. Because you mentioned that there were tools such as remote patient monitoring that were a key part of this, but healthcare providers, the nurses and physicians on the end, like they don't practice remote patient monitoring, right? They practice healthcare, and they practice how you can personalize care for patients and provide them with the best care possible. And so it's really important that the technology is integrated and is a part of how they deliver care, but recognizing like that is a piece of it, not the totality. And so I'm really excited for this conversation and love the mission focus.
Okay. And one aspect of RPM that's really gaining favor now is because of what happened with the pandemic, reducing in-person visits. This program, as Kim mentioned, came out, was launched right about the time the pandemic really picked up steam. So the question is to Isaiah, how did the pandemic affect this program, and how do you balance competing bandwidth priorities before, during, and after launch?
Whoa, that's a very good loaded question. And the best way I'll answer it is by organizational goal and mission. If you don't have from the top, from our senior team, if you don't have a collective, this is what we're going to do, you can't affect the bottom. You can't affect the back of the house, as Kim would state, or the front of the house. And those are some of the terminologies that we introduce: is the front of the house, the back of the house. How do we collectively come together? And one of the things, and I'm going to say this in such a social media way, one of the things we designed, like everybody else during the pandemic, is hashtag Team DVCH. And that can't be more apparent here. It was not just an IT project. It was not just a quality project. It was everyone's project, from CEO on down, from clinical, operations, finance, billing. And I know we're getting to that. So how do we do that? We make sure we're aligned. And so in the pandemic, you see from a technology perspective, everything that was bubbling up to the top, telehealth, telework, all of these things just were able to quickly be able to be enacted. And then you just put healthcare as the special sauce, as I call it. That's a win-win. And, I won't get into my basketball or my Mamba mentality that I like to do because I'm a Kobe Bryant fan. That's what it's getting me fired up now, because that's what got me up into work. For Kim to say, hey, we can do this. We can change UDS metrics. Oh, you got me, Kim. I'm a team player. Here we go.
All right, Kim.
Yeah, so primary care is a team sport. I did get this one in with the sports analogy. It is a team sport. So we did have various members besides the ones that we had mentioned. So I'll get a little bit into the weeds. We'll get into it. We have a clinical pharmacy team that actually works with our provider team, and our care coordination team, who did the bulk of the work with our providers to be able to deploy this program and make it actionable. So those were some of the bandwidth priorities that we had to look at. Who could do what and how fast could we do it? Additionally, we had to really partner with external stakeholders like our EHR, Next Gen Healthcare. We also had to partner with the remote patient monitoring platform, Validic. We also had to look at these other equity pieces, these external stakeholders that I needed to have the program to be successful, like the Food Trust in Philadelphia, to be able to address some of our social determinants or social drivers of health needs that our patients have. We also went through a chip issue with one of our cuffs that we were using. So you didn't have, it wasn't an easy launch to do, because we were doing it in the midst of all of these competing priorities, whether they be internal or external. And we had to figure out how to design this program to deliver care outside the walls of the clinic while having these guardrails up, and then making these alliances inside and outside the organization to be successful.
Okay. Drew, is this type of program indicative of what you're seeing now with healthcare organizations?
Yeah, it is. And I think that what is really interesting is that to the points that Kim and Isaiah made early on in the pandemic, it was just response. We just have to get something going, right? And I think the good thing was most healthcare organizations responded extremely well. And got things up and running that were necessary, that were not in place before, in a very, very short amount of time. And so I think that what that showed us is that we can drive change when the right incentives are aligned. We can have technology that clinicians and patients are willing to adopt and utilize. And I think that now, because we had to throw things together so quickly, now folks are taking a step back and saying, okay, now, how do we really do it, right? Like we got something in place that worked before, but how do we now do it for the long term? How do we do it for scale? How do we do it where, in a cost-effective way that's going to make sense financially for our organization? And like we're now seeing healthcare organizations ask these much harder questions that are really designed to kind of pressure test sort of what was put in place in the short term with kind of these long-term views to understand, how can we make remote care part of how we deliver care? What does that mean for our organization? What does that mean for our clinical teams, especially when we're seeing, the stat that I've seen recently is 47% of healthcare workers are planning to switch their to change their job by the end of 2025. I mean, that's a terrible, scary stat, right? So we still have more people who need more care. We now have, the same or often fewer clinicians to deliver that care. These technologies can help oversee a population, help prioritize the care for the folks who need it the most. But how do we do that in a way that actually helps healthcare providers deliver the care in an efficient way? And again, in a cost-effective way that healthcare organizations can actually sustainably support.
Yeah, certainly the pandemic era environment for launching telehealth was a little bit easier in that there were some waivers in place, a little bit more freedom to use different technologies that we're not seeing. You're not seeing now past the public health emergency when some of those waivers are gone. It's kind of an interesting landscape right now for telehealth and remote patient monitoring. Now, in getting this going, Kim, what did you notice were the limitations in resources or funding that you had to deal with, you had to overcome in order to get this program up and running?
You mean there's actually like financial limitations when you launch a program? Get out of here. I have never heard of such a thing. Never. I think what you were saying related to as we get further and further away from the public health emergency and this additional support starts to expire, one of the things that comes to mind is, yes, we have to figure out how to do it better and leaner and put it through that PDSA cycle. But we also have to think about the fact that in a moment's notice, an organization, an entity, an ecosystem, whatever you want to call healthcare, made changes to put the patient at the center of the center of what they do. So you can't use that old adage anymore that healthcare is too big to make these rapid changes and actually put something in place that works. So yes, we had funding challenges in the beginning. I talked about the initial small grant we had from the Health Control Network from the Health Federation. We also then got some additional supplemental funding, but it was limited. So any kind of grant funding or philanthropic funding is good seed or start money. The sustainable change that we really want to talk about is that policy or that reforming of that large scale of how we are going to reimburse with this. And I think that's some of the hard work that Delaware Valley Community Health is doing with its local payer population as well right now. We're really starting to look at that data and determine whether or not we can prove the concept that in the midst of what we were doing and now sustaining it beyond that as the public health emergency expires, how a high touch care coordination model can really benefit the healthcare ecosystem and the patient that we are serving. So there were funding challenges. We did overcome it by thinking outside the box. And I can say that the leadership at DVCH with my CMO and my CEO and my CFO, they were always willing to listen to me and take any kind of suggestion I thought about to be able to make it happen. And I think that's what we need to do organically in healthcare is really start to think about how we can deploy these programs in a creative and innovative way. Technology really can augment the care that is delivered in clinic and outside of clinic. And I think we're just starting to scratch the surface.
Yeah, and this is certainly a good primer for any FQHCs and rural health centers and other clinics out there that are thinking of launching programs like this. Isaiah, what were some of the barriers or challenges you saw in the program that you had to overcome to get it up and running?
Yeah, again, another good question. And I'm going to layman my answer by starting with I'm a technologist. So everything technology just really, really excites me, except for those Android users. If you're an Android user, we'll fight later, team iPhone all day. However, I digress. Here's from my position in my seat where I really take it to heart and saying that, okay, there's all these devices out there. There's the 21st Century Cures Act. There is an EHR. There is RPM solutions all across the country that were coming out of the woodworks to suggest that they can do this, suggest that they can do that. But it's really in the actual tactical implementation of these things where the nitty-gritty gets to weed out the others. So it's my slow yes in that process. It's making sure your RPM solution and or module tag along is able to perform at a high degree of cadence and competency. What I mean by that is we're not just plugging it in from an interoperability perspective and it brings our EHR down. Okay. The second thing is from a security perspective, because you're adding devices to now your entire network. So we all know, and all of us in healthcare still have fax machines. I can't tell you why we do it, but we do. But the same security principles apply for these devices, because we know from cyber security and cyber regulations that these devices, if not firmware upgradable at the PDSA cycle that Kim talked about, that's part of my job, is to make sure that these devices are on a cadence of firmware updates so that when we do select it, that they are able to work. But then second to that is it patient friendly? So I may have an iPhone 14. Someone else may have an iPhone 11 or an Android device. Is this device, this Bluetooth device, multi-compatible with a wide range of devices to be supportive to our population? In an underserved population, that may be a different profile. They may have an Android or a government issue smartphone. Can this device attach to that? Because it's nothing worse than having technology that doesn't work for the primary care providers that need to actually act on the data. So while I suggest it's all lovey-dovey, here are some of the internal tactical that we use just to get it to work. And I'm happy to say that's why we're doing this actual webinar, right? Is that all of these tools have passed validation via Validic, via Next Gen Healthcare, via Welch Allyn Bluetooth devices. They all passed my high level of screening. And you can't do this without the funding, as Kim talked about.
Great.
Yeah, that's right. And just to, thanks for that, Isaiah. And just to add on, so a lot of that that work on getting the iOS and multitudes of Android flavors supported on the app was work that Validic has done to really test and support and try to make sure that we've kind of whack-a-moled all of the different tech issues that can come up when you're supporting multiple platforms. And it's one of the things that's really important about having a bring your own device, like a bring your own smartphone program, where you download an app. It's gotta work across multitude of apps and solutions. And that's something that's really important to us for us to support. And what we've seen across our patient populations, across customers, is that 3/4 of patients are still recording readings twice a day after 90 days in the program. So it's really sticky. 3/4 of patients feel like they're receiving better care. Over half of the patients enrolled in these programs feel like they're able to better self-manage their conditions. And those are the things that you really want, right? When you engage patients in this, you want them to start to be able to understand how to better care for themselves and understand what their role is in these programs. And, I credit clinicians like Kim, as well as technologists like Isaiah, who are bringing all of these pieces together to support patient populations so they can start to really help to drive better health outcomes for themselves.
Nice. Okay. Next question here is, we're going to talk a little bit about the patient population that's involved. It's a very specific population, very high acuity as well. Kim, how did the risks of a high acuity population affect the program's launch and success?
So many times healthcare organizations or entities are leery of implementing an additional service line that's going to take place outside the walls of the clinic. They're concerned about any kind of risk or any compliance issues related to it. Other webinars that I've been on, that is the standard question that comes up, or how did you mitigate those risks? DVCH did that through, again, that team-based approach. So not only did the clinical community look at it, the technology community looked at it, our compliance department looked at it, we looked at it from our pharmacy lens. We really had all of those team members at the table to really mitigate or put those guardrails up. It doesn't mean that we had a fail-safe program. It doesn't mean we didn't have any pain points as we went through this. It does mean that we put up a program that was risk tolerant, that we felt was safe enough to deploy in a time that we needed to take care of our patients. And DVCH does really stand by the mission of, we put our patients at the center of all we do. And that is how we deployed it in a way that was risk tolerant, but was effective.
Okay. Isaiah, can you answer that question from a technology perspective? Were there certain technical risks involved?
Yeah, anytime you do something with technologies, there's always a risk. There's a risk of device failure. There's a risk of security implications. There's a risk of it being standardized across a multitude of disciplines. And so one of the things, again, I'm going to talk about that Mamba mentality because it's what's apparent here. And what I mean by that is, we didn't just select the first device that came to us as a compatible device. We actually looked through a list of 100, 200 or so devices and really fine-tuned to say, checkbox by checkbox by checkbox by checkbox by checkbox, it actually can work for us. Not every situation has every customization. So you can't just vanilla box a solution. You actually have to put some thought into it and say, all right, this is how Delaware Valley's communications or technology or clinical outcomes are driven by the way that we do it. So here's how it has to work for us. So it wasn't selecting the first one that was thrown at us. It was actually taking the time to put into making sure the devices and the application that tied into devices were fully tested before implementing. But we did not say that we could not do that. I'm going to stress that again, because technologists out there, sometimes we just say no first because we don't want to do it. Delaware Valley did this in the middle of a global pandemic where we had no telehealth and no telework prior to the pandemic started. So in the midst of us sending people home, in the midst of us caring about for a very high acuity population in an urban market, we did this. So it's possible. It's possible. And I'm going to stop there because I'm getting on my soapbox and I come from a long line of Baptist preachers. So you give me the mic, I might go a little long.
Yeah, no, you're exactly right. It's technologists and clinicians, I think, is what I see at healthcare organizations, where it's really easy to start to say no. It's hard to get a room full of people to say yes without somebody saying no. And one of the things that I think is that I've learned from your example at Delaware Valley, just to give you a kind of a bit of a background. So Validic works with a number of organizations, including one of the organizations we work with is Kaiser Permanente, where we're powering the largest personalized care program in the country. So there's been over 300,000 patients enrolled in that program, over 7,000 enrolling clinicians, like really big scale, everything from diabetes, both type 1, type 2, gestational, as well as hypertension and heart failure and acute hospital home, like many kinds of programs across those patient populations. And outside of that, there are a lot of other programs we support, but they're all, getting up to speed and getting up and running. And then all of a sudden, out of the blue, we have Delaware Valley, who is a client of ours through our mutual partner with NextGen. And Delaware Valley is going from 100 to 200 to 500 to 1,000 patients, like really rapidly. And we all, like, we saw this on our stats, and we said, we gotta talk to Kim and Isaiah, like, what's going on in Philadelphia? This is amazing. And what we found, I think, when we really started to dig in, is you did that work up front, but also you took an iterative approach. And you said, okay, so we're gonna start here, and we're gonna learn, and we're gonna adjust, and we're gonna adapt. And like, you didn't say we have to have the whole system designed perfectly from start to finish, that's gonna support 50,000 people, and then we'll enroll the first one, right? You said, no, let's enroll the first ones and see how it goes, and iterate and continue to improve. And that's the mark of success that we see with organizations that start to scale, is that you're willing to take that first step and learn. And so I applaud you all for doing that. And it's something that I too often see health systems fail at, where they kind of get in their own way and don't set themselves up for success by sort of self-limiting the programs before they even start.
Yeah. A good lesson plan for healthcare organizations looking to do something like this in the future is to plan it in stages. Next question here is kind of multifaceted. Let's talk about the benefits, the value of a program like this. Kim, what was the value of this particular program to the patients you served and to the providers who were involved with this? What value did they gain out of a platform like this?
Yeah, so the learning culture that Drew described, that DVCH deployed, is really key to what our benefits, our providers, and our patients gained from this. I'm going to take it even a step further after I talk about providers and patients, and talk about the org benefits and also the payer benefits. So our provider benefits through the use of team-based care really have an actionable way to engage their patients, where we were telehealth, but now we are actively enrolling in point of care. So they come in, can have their blood pressure screened in the office. The provider wants some additional data points to really make some decisions related to their care. We can enroll them in the clinic at that time, or they can go home and we can enroll them remotely and make those actionable changes. So for the provider population, it was something that was actually tangible and actionable at the time of engaging with the patient. That was important. With our patients, the high touch model really evolved from April all the way through till now. So we started to add additional layers as we were learning. So we were looking at, how do we incorporate our social determinants of health screeners? How do we make sure that we have resources if we're going to ask those questions? How do we make sure that we have a smartphone or a tablet for a patient that doesn't have access to technology? We don't want to make any of those gaps larger by implementing a program that we don't have an answer for our patients. That is not what DVCH is all about. And we did make sure we built that into the foundation of the program as it evolved. The org benefits are really that partnership, that value-based partnership out into the community. So it's those partners with the American Heart Association and the food bank and the food trust to be able to provide those resources that this program reinforced for DVCH. And then also from a payer perspective, I know we have some health plans in the audience. This preliminary data really shows that synergistic relationship that can happen with remote patient monitoring and a high touch care coordination model. And I do think that that's going to be used to articulate what value-based care can be in a primary care setting. And that's where we all hope to get to. I know Isaiah's going to have a totally different perspective on that because it's going to be tech, but I just gave you the clinical piece.
Yeah, I do like your inclusion of food banks in this program. There's so many of these ideas now that extend beyond the clinical care pathway and to incorporate some of these new services that affect social determinants of health. Yeah. Yeah, Isaiah, let's talk about the technical aspects of this, the benefits.
Being a technologist, my response to this is more than just technology. It is truly the WHO's definition of a whole person. And not only the whole person, but the whole organization. So looking at the quadruple aim, making sure we take advantage of all of those things that we do well and make sure our staff is not burnt out at the same time. That time frame, again, was a pandemic, a global pandemic. And so when you're doing things like this, you want to make sure that you do it in a way that's iterative, like we suggested, but that also has built-in audibles in my football speech, so that if something goes wrong, you quickly Peyton Manning the offense and you say, all right, we got to go this way. I'm not even going to talk about Kansas City or any of their audibles. I digress again. However, the real true thing about this is not the PDCA cycle, but the PDSA cycle. And I talk about this all the time because there really is a difference between checking and then acting and then studying and acting. And that's why I like the PDSA a lot more than the PDCA, because you really have to study what's actually happening, because that actually predicts how you react to the situation. The next thing I want to talk about is putting patients in charge of their health. FQHCs are in charge of primary care. This is what we do well. We do social determinants of health well. We've had population health systems for decades, and we have all of that data. For instance, at Delaware Valley Community Health, we don't just see the mother or the father, we see the grandmother, the grandfather, the grandchildren, the great-grands, and we have all that data. So when we're looking at the whole patient, we're looking at them from generations coming to the same primary care office to then say, all right, these are really prime patients for remote patient monitoring. But then if we can identify a gap in their social determinants of health, we also have tools like the Prepare template, which is a national standardized template for community health centers. And by ingesting that data, that's how we can say, all right, this family has a food insecurity. Let's partner with our food bank. This family has a technology barrier. Let's partner with federal organizations to be able to deliver a smartphone. But then when you're delivering these types of additional services, you're truly making whole people with healthcare. And that's what gets me up every day. That's what gets Kim's up every day. That's what Delaware Valley Community Health has been doing in our market for 52 years. I digress.
Yeah, man, it's what gets us up every day too, as a technology company, and just to, name it. I think what's really important about what you just brought into the room, both Kim and Isaiah, around the people and the community and the families and the social determinants and the food banks, and this is all a part. It's a part of the whole person care experience, right? And so often I think you hear maybe from technology companies and they're saying our technology is great. And by the way, I think Validic's technology is great. But what is really important is this is it's a piece of the broader puzzle. And without the care team and the family and the patient understanding like the whole picture, and having all those resources, that piece doesn't work. And so the way I see the work that we enable at Validic is that remote care it's like a commitment device. And so when a clinician enrolls a patient in a program, now that patient knows, they know their role, right? Their role is to take their blood pressure for, in the example we're talking about with hypertension, right? As well as to take their blood pressure medication. And they know that if they don't take their readings, that the clinicians are going to know that and reach out and say, hey, what's going on, right? So there's a commitment device there. And the fact that there's a commitment device, now the patient knows, like, patients don't like disappointing anybody, let alone their care providers. So that's why they want to, that's why they take the blood pressure. That's why they participate, and they want to be a part of this program. But over time, what they learn is, or what the data does, it provides educational opportunities. So Like as an example, we have a patient advocate that we work with he's a diabetic patient, but he was introduced to Validic a number of years ago. He had uncontrolled diabetes for over a decade, and he went to a healthcare provider. He was already tracking his glucose. It wasn't working. His A1C was out of control. He thought he was eating healthy. He thought he was exercising. Like he thought he was trying to exercise as much as he could. So the doctors, when they would say, well, you got to eat healthier and exercise, he was trying to do those things. So he went to a healthcare provider that Validic was working with, where his glucose data went into the EHR. And the second visit, his healthcare provider is able to look at his glucose readings and say, hey, I can tell you're tracking really well, but what's happening in the evening, because your glucose levels are higher than they are at other times. And it turns out he was having what he thought was a healthy snack with his wife and kids, as they were sort of watching a show on Netflix at night. They're watching, he was eating some popcorn, and it was unbuttered, unsalted. He's like, it's healthy. It's a healthy snack. And the nurse was able to say, hey, look, I don't know if that's going to be healthy for you with your condition. Like, try cutting that out. So he cut that out, and within 30 days, his A1C dropped by 0.5 point, right? And so when the doctor was saying you need to eat healthier, he's like, I'm eating a healthy snack, right? And so the data just helps have a better conversation and helps the clinicians understand a little bit more how to tailor the intervention to the patient and have a better conversation. And I think that's why we see such strong clinical efficacy. It's one piece, but it's a really important piece with data that we don't otherwise have.
Yes, good. Yeah, we've got about another 2 to 5 minutes, maybe 7 minutes left before I pass over to Sean for the audience Q&A. And we have like 3 questions here. I'm going to kind of group them all together just so we get to as many of them as possible. Patient engagement, patient perspective. How do you, I'll ask this question to Kim, how do you get patient and I guess provider as well, feedback about the program and to encourage engagement, and how much does that affect how the program is operated?
Yeah, good question. So when we're looking for those pieces of information to come in from the patient, that peek into the evening that Drew was talking about, we have those same aha moments with the blood pressure readings, where you're checking outside of those normal clinic hours to get that information. And whether it's the care team reaching out and saying, hey, I've noticed you haven't been able to connect, you haven't been able to transmit what's going on. It's those pieces that the technology enables us to connect with the patients in the real-time moment. The way we were able to keep them engaged was the amazing work of the care team, the effective way the systems worked because of that interdisciplinary collaboration that Isaiah has talked about. And then also that actionable data that comes back kept our providers engaged, because they were able to make those informed decisions with our clinical pharmacy team to titrate meds, make med combinations, because again, going back to those social drivers of health, if we have a patient who is on 2 medications and because of this great actionable data, we can put them on a combo pill that is more cost effective, it really does then engage the provider to deliver that patient-centric care, and also the care team, because they feel like they're making a difference in that patient's life right there because of that data.
Yes. Okay, Isaiah?
I want to take a different spin at this and just talk about the future of programs like this, because technologists out there, I get this question all the time, is like, how do you really implement something like this? Are you standing up a bunch of different servers to do this? What really is your technology strategy? And for us, the future, because of programs like this, has really allowed us to have a hybrid culture, because in order to scale this, and then before the pandemic, this was a lot of hardware infrastructure. This was a lot of IT resources deployed just to get servers up to have a device connect into it via your VPN, via your technology information stack. But what we found is that by going hybrid and making sure that the solution provider had their SOCs too. Your solution provider was HIPAA certified. Your solution provider had all of the checks and balances that you could verify and then bring it into your hybrid sort of cloud approach. that made scalability easy, because now it reduces the cost that in an FQHC as a nonprofit, we want to make sure we're spending our dollars wisely. So to be able to quickly spin up in a cloud infrastructure made it applicable to be successful, not only in the POC, but in the future launch. So for all my technologists out there, these are some of the things that we can take advantage of in that hybrid nature.
Yeah, absolutely. And just to add 2 quick points there, I think Kim mentioned the clinician experience, and I think Isaiah was talking about this from a technology perspective, but like, how do you actually implement this? And Kim was talking about how clinicians can reach out to patients, and one of the things that we often hear is, well, like, clinicians are already overloaded; they're already getting too much information. Like, how do we set alert? Like, how do we do this, like, and manage all these alerts when patients are using the devices all the time? And so 2 things there. One is, just as with any clinical program, upfront education is really important around, like, hey, look, if you're having a serious medical event, you need to call 911, right? Like that's, I don't know why people think, like, just because there's remote data being captured, like, all of a sudden this has to be like they're in a hospital bed. Like, that's not the case. Like, if somebody's having a medical event, they should always call 911. These are not intended for, the triage of serious medical events, right? And then the second piece is that I always tell people, it's like, if your clinicians feel like they're getting too many alerts from the program, it's probably in the program, like, the program design is probably wrong. Like, these should not be, like, Kim, your team can always go and check in on a patient and review the readings and see how they're doing, right? If they're getting alerts, if they're getting too many alerts, then they probably have set the thresholds too low, and they need to, like these should not be FYI alerts. Like, FYI, somebody's blood pressure is reading a little high, right? These should be like, oh no, we need to reach out alerts. Like, oh, this is trending in the wrong direction. Like, we need to intervene and actually have a conversation with this person. And so I think that's, like, a really important distinction too, is that setting up the proper expectations in the program design for the clinicians, as well as kind of what the patient role is, I think is a really important part for the success and scaling of these events.
Okay, one last question. We get just a couple minutes left before we go to the audience Q&A. How is a program like this going to evolve? What's your roadmap for doing more with it? Where can it go? And I'm going to start with Isaiah on this one.
The sky's the limit, honestly, because, but I'm careful with the sky's the limit, because there has to be a reality to the sky's the limit. But I like to start with the stars. And where I think it can go is adding additional chronic conditions to RPM, not just SMBP. So I go a little bit higher and say, how do we do weight? How do we do height? How do we do some of those additional things that can be done in the home and just add them into the clinical opportunity? The second thing I also look at is, how do you continue to extend your clinical team outside of the walls? Mental health, behavioral health. How do you extend that into some of these primary care opportunities from a technology perspective? So if there is an issue when you start adding weight, when you start adding height, when you start adding some of those things, how do you get them to the right provider so that they can help? Is that via telehealth? Do you integrate that with your telehealth application? I can give you my 5-year roadmap, but I shouldn't do that, because I had one and then the pandemic blew it up. So I will not give that to you right now, but that's what I'll stop and just say. I think the sky really is the limit.
Nice. Okay.
And any roadmap is only good for the next quarter, Isaiah. You know that.
Changes, yes. Okay, Kim.
Change is inevitable. And yes, I would love to say that I have a 5-year roadmap, but I don't, because I do think we have to look at what the funding structures are going to be like for these programs, especially for our community health centers and our FQHCs. I do believe that remote patient monitoring can be part of a very strong chronic care disease management program that is part of still seeing the patient in the clinic, It is something that we can use to mitigate these social drivers of health for our rural clinics and also our patients who have transportation issues or childcare issues that they can't get into the clinic. And I think we need to make sure that those voices are heard when we talk about funding, because we are missing those patients because we don't have something that speaks to it. And that was something that was really key when we designed this program. And if it evolves beyond remote patient monitoring for blood pressure, which I hope it does to diabetes, we want to make sure we have those same tenets in place to address the needs for all of our patients.
Very good. Okay, Drew.
Absolutely. Yeah, and just to add on to that point, I think that Kim, building on what you just said about people who maybe can't make it into the clinic, et cetera, like I do think this is part of a strategy that includes in-person visits. I mean, at the end of the day, healthcare is a human experience, right? It needs to be that. But one of the things that I took away from a conversation I had with a clinician a while back was that, when people maybe don't participate in these programs, which we're never going to get 100% participation, right? But when people don't participate in these programs, the fact that most of the people who are enrolled do participate and remain active, and you kind of know how they're doing, it allows the clinical team now to spend more time with the people who aren't otherwise engaging and to engage them in ways that are helpful for them, while you're also able to kind of see how everyone else is doing, right? So you can take that population health approach. Isaiah, to your point, FQHCs have been doing population health for 20, 30 years. You can keep that population health mindset, and the data kind of helps you oversee the population and know who's healthy and doing well versus maybe who needs a little bit more time and attention. So I really appreciate the conversation. Again, just want to echo how great it is that Delaware Valley is taking this to the community and serving those who are traditionally underserved with these technology programs. And I'm really honored to be able to share the virtual stage with you all today.
All right, thank you. And with that, I will pass it on to Sean now for some of the audience questions.
Great, thanks very much. First question, how do you encourage patients to remain engaged in the program over time?
I can start with that, and then I'll toss it to Isaiah, because this is something that we kind of worked on together. So when we started the program, we wanted to make sure that we had something tangible that the patients went home with. So if they did an enrollment with us, either online or in person in an abbreviated visit during the height of the pandemic, they went home with instructions that they could refer to on how to re-enroll if they got disconnected on the app, to be able to reach out to who when it was a specific person. Drew actually touched on like tech support and things like that. So I think making sure that you have all of those pieces will eliminate some of those pain points that will have not only patients, but providers disconnect. Isaiah and I had a very strong conversation about what noise we wanted to keep out of the EHR to make sure that our providers stayed engaged as well. I'm sure he'll take you through some of how we did that and refined it as we went through the process.
Yeah, Kim, I'll take the alley-oop and dunk it. I'm trying to decide if I'm going to be Kobe or Michael in this conversation for this one, but I think I'll go Michael on this one. So, what Kim suggested is right, but let me again take the step back and say, as a technology team at Delaware Valley Community Health, what I say to my team is that our jobs don't stop once we put the device in production. And what I mean by that is we have to support not only our providers, but our patients in that. So when there's a Bluetooth device disconnectivity, how do we troubleshoot that? So I like for my team to extend themselves further than what's traditional. Secondly, we want to make sure that data that comes in is customized to the provider's liking. So we work strongly with Kim and her team, work strongly with our CML, Chief Medical Officer, to suggest, hey, here's how the data can come in. What would you like? And then we use our intellect as technologists to make sure we get as close as possible to what exactly it is they like. And then we take it through the cycle over and over and over again.
Got it. Okay. Next question. I'm a maternal fetal medicine physician, and I'm curious about what work is being done for our women with hypertensive disorders of pregnancy related to chronic gestational hypertension and preeclampsia. Thank you. Any insights on that?
Yeah, I'll take that actually. We had just talked about a roadmap, and I didn't say I had a 5-year plan, but I do have our OBGYN population on my to-do list related to remote patient monitoring. So I have a meeting set up actually with some of our clinical team tomorrow to talk about how to start to use these tools, our home SMBP tools, to deliver care and meet for our maternal health needs. We do see that this is something that could be helpful. We also recognize that with the additional data that's going to come in from home on top of the repeat visits coming into the clinic, we could either cut down on some of those clinics and the travel time coming in, especially if they have those SDOH needs, or we could actually call them in sooner and mitigate anything that's going on because we're getting that information. So our maternal health population is on the roadmap, and it is something that we're actively doing. So.
Yeah, Kim, you nailed it. And just for the sake of time, I'll just say I also want to add gestational diabetes into that as well. We run solutions for some clients with gestational diabetes as well, and see it's a very, very engaged population. And they're only in the program for 4 or 5 months, right? For obvious reasons, but it really does help them manage those conditions, and to your point, be seen earlier if they need to be, or potentially even avoid some visits if they're doing well in managing that condition. So thank you for that.
Okay, a couple more questions I'd like to squeeze in. The next one, can you please explain how the blood pressure readings go from the blood pressure machine to the clinician? Is clinic staff involved with retrieving the information and tasking the clinician with the information? Who's in charge of addressing technology barriers and challenges with patients?
So I'll start it off again. I can just talk about briefly the fact that we did use our own clinical staff to do this. We did have a platform that allowed it to be malleable for us, and I'm sure Drew and Isaiah will get into a little bit more of that. It does allow for tasking, and it does allow for it to communicate to the EHR. I think we are at a stage where we're going to continue to evolve that because we're learning to see what we need to be able to keep that patient at the center of all we do. Drew?
Just echo that and say that your clinical teams can take this on, but it needs to be not, quote, not another thing to do. It needs to be part of the clinical workflow. And the process of getting the data connected up through for the patients is that once Kim's team enrolls a patient in the program, they receive an email with instructions to download an app. So they download that app on their phone, and if they need support, they can. I don't know, Kim, if your nurses have the patient download it at the visit or not. Do they often do that? So then they can kind of walk them through that process. It's a very quick setup process. They just click a few buttons, create an account, and then they receive the blood pressure monitor and pair that to the device. Pair that to their phone. There's instructions on how to pair it in the app. It's very straightforward. And the nice thing about the way the app and the device works is that as long as the phone is on and within range of the device, the patient doesn't even need to open up the app in order to take a blood pressure reading and have it be sent automatically to the Delaware Valley team. They just take a reading, the app picks up the Bluetooth from the blood pressure cuff and then sends that directly to the Delaware Valley team. So it's available for them the next time they look. So it's a very quick, easy process. It's the same solution that we use to run many other programs. And we definitely have worked to, it's not perfect, but we're always perfecting it. So we're sort of climbing that logarithmic path toward perfection on patient experience.
Okay, and just one more question I want to squeeze in before we wrap up. Did DVCH use their own clinical staff to monitor patient data, or did they outsource the monitoring to a third-party clinical team?
So I was able to capitalize on an existing team that we had. That doesn't necessarily mean that all FQHCs or all primary care offices have that infrastructure. We were blessed to have that. I'm not here to advocate one way or another, but I did have the ability to operationalize it through an internal team that did the great work with our patients, enrolling in person or remotely.
All right. We are just about out of time. I want to thank everyone for their participation today. Thank you for joining us. Thank you to our sponsor, Validic, for making our session possible, and thank you to our speakers. Just a reminder, everyone, the webinar has been recorded. You'll receive an email with a link to the video so that you can view it again. Thanks again for joining us, everyone. Have a great day. And this now concludes today's discussion.